everyone.
Good morning.
Let's do it the Brooklyn way. Good morning, everyone.
Good morning.
Yeah, now we're talking. That's very nice. Um, I'm so glad to be here, and thank you all too for being here. This is a very, very important, meeting for the transplant program. It is required by the people who pay us the money, by CMS, by UNOS, and by the state to provide this multidisciplinary training every year, so that everybody's on the same page with transplantation. Uh, as you know, our transplant program is the only program serving a very large population, even though our transplant rates haven't met there yet, but they'll get there. But we are the largest in terms of serving a population. Brooklyn has 2.6 million people. Staten Island has about nearly 700,000 people. Queens has 1.8 or so million people, and that is the population that we are serving. And we get some catchment also from Long Island, and then we have people coming from the Caribbean. So if you look at the population that we serve, it's actually the largest in terms of service in New York City. So that's how you have to think. We are located in a place where this transplant program can flourish. It can actually be the dominant player in transplantation for kidneys in New York City. It did that before. We call that the old glories. The old glories are just to think about, but we, as a team, we have to create new glories, right? Wherever we are right now, you have to be part of the team that creates the new Downstate, the new transplant program. Not that 10 years ago we're like this, and then 20 years ago we're like that. Okay, that is fine. Somebody did that. What about us? All right, we have to create new glories. And until we create new glories, we cannot move the transplant program or any other program forward. So that is my message to you. Let's all work together. Let's all plan together. Let's all have the same mission in mind. A mission that is dedicated to service excellence for people with kidney failure who are coming for a kidney transplant. Now, for now, I know you are all doing it. Everybody's geared up. If you look at the Press Ganey surveys, right? The transplant program always has the best surveys in the hospital. So let's give ourselves. Okay, it always has. If you look at it for the last maybe 6, 7 years, every year transplant program is at the top of the Press Ganey surveys. So you're already doing a fantastic job, right? Which is very good. All I'm saying is let's capitalize on that. Let's create some new glories, and let's make sure that the people who are coming here to get a transplant would spread the word that this is the only place to come for a kidney transplant. So that is the message from me. Now, the message that I have, which is more personal, has to do with our new chair. No more new, but our new chair, Dr. Gruzna. Dr. Gruzna is coming. It's very rare, by the way. Just you can, after I say what I'm saying, just Google and see what I'm saying. It is very rare to have a chair of surgery who is also a transplanter. That combination is very, very rare. Do we have it in New York City?
No, actually it's becoming rarer because the chairs at UCSF and UCLA, that were some of the biggest programs in the country, are stepping down or have stepped down. So there are maybe three in total now.
That's it. That's it. All right? So, you see, we don't know these things. I want you to be proud of that. When you have a chair who is also a transplant surgeon, that means that you have access. Like vascular access for dialysis, you have access. If you want to build a transplant program, you cannot build it under that circumstance, then you are missing opportunity. So for that reason, I think we are lucky to have Dr. Gruzna, and I know that Dr. John has built a very viable, high-quality transplant program. So with that combination, we should be seeing ourselves doing a whole lot of transplants, 100 or more transplants in the near term. So thank you to Dr. John for creating all these policies and procedures. He's big in quality. We understand that, and I think that with the quality mindset and with the volume mindset that we're trying to bring, if you mirror the two of them, quality and volume, we are really going to be the best in New York City. So again, you are in the best possible state to run a program. You have all the things you need. If there is anything that I can help from the medical side, I'll be happy to. Myself and Gruzna, we have exact same plan, right? Between us, we have exact same plan. If you talk to him, and then you close the door and you talk to me, you see that the language is the same. That's how much we are synchronized. And we want everybody to feel the same way. We want everybody who's working to create a system to think the same way, because at the end of the day, we are here to serve. I'm going to be retired or be fired. Somebody's going to be retired or fired, and the system has to keep moving. So the system should not be depending on people. It should be depending on quality decisions. The system should be dependent on quality decisions by the people who are leading it, so that there is continuity, there is sustainability. So that's what we intend to do. We don't have any agenda other than to do good. No agenda. We are not here to, create agendas. We're just doing good. So because of that alignment, medicine and surgery, I think if we can continue to work together the same way like we're working in transplant, this hospital would come out of its problems that you all know about. So thank you again. Enjoy the conference. And I'll be in and out of, I have another one going on in oncology. I'm going in and out. But enjoy the conference, and thank you all for coming this morning. I'll go in and I'll come out.
Yeah. Good morning. I'm going to drive you nuts, I know. But what I want to do before I have a formal lecture, what I wanted to do is because we were a small group, and I thought the room would not be big enough for us and we would have to go to the main auditorium, and we don't have to. I thought we introduce ourselves briefly because, you probably know most, we know probably most of each other, but nevertheless, why don't we go ahead?
Good morning, Andrew Denofrio from the Transplant Laboratory.
Okay.
Janet Lau, a dietitian for Transplant and transitional dual palpation and sweeper.
Mm-hmm.
Mary Fontenelle, outreach liaison for Transplant.
Susan Sanders, outpatient transplant social worker.
Victor Ocasio, data manager for Transplant. Devin John, Transplant.
Kevin John.
Civil scientist.
Catabla Transplant Nephrology.
Good. So, first of all, thanks. For all the ones that are here.
Everybody knows me. That's
Well, Carrie, everyone knows her. I'll give her credit in a second anyway. It's great that you're all here. Obviously, transplantation is much more. So, many people are not here for whatever the reasons are. But I think it's great that you came, because in order to, it does take quite a bit of organization to put a program like this one together. And Carrie, I must say, did a great job in putting the topics together. And I'll just briefly go through them and tell you why I think they are important. Muriel Briggs, is she coming?
Ms. Briggs is out. Ms. Easy is going to be giving a
Okay, good. So the waitlist management and evaluation is important because, as you know, UNOS grades and flags programs by performance. So you all know that, two of the hard criteria are 1 year graft survival and 1 year patient survival. So what UNOS does is it bases the individual center's outcome on what would be expected in the entire country versus what is observed. So we are observed, and our observed number, that's actually the one that we create, is compared to what is expected. And using a bunch of statistical methods, they will let us know whether we are within that framework. If you're not within the framework, UNOS can hold the program or can actually put you out of business. So quality, that's what Dr. Salifu said, is extremely important. There's another measure that is important, that is how many of the patients are transplanted off the list. Traditionally, with everything that happened about 10 years ago, the numbers have gone slowly up, and we're slowly catching up with the number of patients transplanted off the waiting list. But we are not there yet. I mean, there we usually get a red flag, but we have made progress in that regard. But it's very important to understand, I mean, the wait list, the criteria, what it means in terms of outcome, and what direction we are going. Carrie is going to talk about the UNOS allocation and the new criteria that have been put in place. You can imagine an organization like UNOS trying to put rules into place. It's like Capitol Hill talking about tax reform. There are lobbyists coming out of each corner, and everyone wants to do and have the best for his or her interest group. There are the people that are fighting for patients with polycystic kidney disease, and that the only thing that they care about. Then there are patients out there that fight for diabetes. Then there are the pediatricians. You know, everyone knows, I mean, kids are really, really important. So, I mean, the allocation is done in such a way that children clearly are advantaged over, let's say, older adults. But once a rule is spelled out and goes out for what they call for public comment, I mean, there are I mean, hundreds and hundreds of emails from all kinds of interest groups that try to push, I mean, their cause. That is true for all organs. It's particularly true for the kidney because most transplants, as you know, are kidney transplants. It is much more ferocious when it comes to liver transplantation because the liver is a life-saving organ in contrast to the kidney. Kidney fails, what you do, you go back on dialysis. If you don't get a liver, you are dead. So that's why these comments are very important, and UNOS invites everyone, particularly from the transplant community, to comment on whatever the new allocation policy is going to be. Carrie is going to talk about the new kidney allocation policy. I remember that in 2002, we started talking about a new allocation policy. It took over a decade to get to where we are. And even the new allocation policy, I mean, as always, is not perfect. Carrie also is now member of the MPSC committee within UNOS, which is the most powerful of all programs, the Membership and Professional Standard Committee, that really looks into the failings and deficits of each single organ across the country. They have the power to penalize individual surgeons, but also to penalize complete programs. So a lot of the press that we have been hearing about transplantation, aside from, I mean, all the great news in the 80s, 90s, and so forth, about buying organs, having people go to other countries, buy organs there, then come back and expect us, all of us, the taxpayer, to pay for, I mean, some of these transplants that were done, maybe to them in good faith, but poorly executed, they come back. Those are all issues that UNOS and the MPSC is dealing with. So allocation, UNOS, MPSC is important. HLA and cross-matching consideration. When I started, there was only one technique to do cross-matches. It's completely changed. DSAs, we take that for granted. DSAs are donor-specific antibodies, meaning the body, after a transplant, generates either pre-existing antibodies, despite the fact that you're immunosuppression, and these antibodies, if you're dealing with autoimmune disease, will attack the organ, the newly transplanted organ, as was done with a native organ, or new antibodies that are generated anew. We had no clue in the 80s and 90s that, I mean, there were antibodies that could cause damage to the organs. So a lot has happened with regard to HLA matching. All we knew back then was that there were groups of antigens that were considered to be related to each other and that might have been advantageous with regard to transplantation. But that really was all that we knew at the time. Back then, because we didn't have good immunosuppression, matching was very important. And I'm primarily talking to the nursing staff now because you're taking care of all these patients, but I think it's also important for you, to understand the background where we are coming from and where we are going. But at the time, we didn't have the immunosuppression that you are now familiar with and that you are administering to the patients, whether it's Prograf or Cellcept or whatever it is. So in order to have good outcome, what we had to do is we had to match the donor with the recipient. And we know since the 1960s that there are what we call 6 antigens that are important for the matching process. HLA-A, HLA-B, HLA-DR. There are more, but those are the 6 big ones. And we have 2 of them. And they're inherited, one from the paternal, from the maternal side. There are 6 antigens. So that's why we call a 6 antigen match an identical match. And we want to make sure that these patients actually are the ones that have the best results. Because if you go back to, the first successful kidney transplant in the 1954 that was done in Boston by Joe Murray, who later received the Nobel Prize for it. That was not the first kidney transplant in the world. It was the first successful transplant. It was the first successful transplant because it was done between identical twins. At the time, no one had an idea about immunosuppression. Even steroids, the use of steroids in transplantation was not standard. People were talking about maybe using steroids, but no one had a clue. Azathioprine, Imuran, that we're not using anymore, or by and large not using anymore, did not come about until the 1960s. Cyclosporin, not until the 1980s. Prograf, not until the 1990s. Same for Cellcept. So early on, all that we could do were transplants between identical twins with good outcome. And that's what Joe Murray showed, and for which he got the Nobel Prize. The interesting thing is he didn't stay in transplantation despite being so successful there. He was the chief of plastic surgery and reconstructive surgery at Harvard until basically he retired from Harvard. So Dr. Noren is going to talk about HLA and cross-matching. Dr. Asagi, one of our initially non-transplant nephrologists, now is really part of the team, and he was gracious enough to go to Wisconsin to learn about pancreas transplantation, which is a completely new field, and I'll talk about that in a few minutes. But he will really give you an idea the similarities between kidney and pancreas transplantation and the differences. Pancreas transplantation is a complete different animal. When we do a kidney transplant, we hardly see surgical complications. Maybe 1 or 2% of all kidney transplants fail because of blood clots, leakages, or whatever. Liver transplantation is different. The fate of the patient is decided or determined when the patient is on the operating table. It is not uncommon, even in experienced hands, to lose a patient on the table. In extremes, patient may require 100, 200 units of blood during the procedure. This is a completely different animal, and we are currently not equipped, to do liver transplants. But if we want to be a serious academic center at some point, liver transplantation, heart transplantation has to be part of it, because we need to train our staff, our nursing staff, we need to train our medical students, we need to train our residents. And not everyone will find a job at a place where they don't do liver or heart transplants. But if you apply at places where they do them and you don't have that experience, you are disadvantaged right from the get-go. So that's why it's important long-term to get back to these transplants that used to be done, small numbers in the 1990s, but since then have not been performed anymore. Pancreas transplantation is completely different than the other two, kidney and liver transplantation. Unlike liver transplantation, we usually do not lose patients on the table, very rare. But unlike kidney transplantation, it is much more complicated when it comes to surgical complications. If you are a pancreas transplant surgeon, you have to be not only a transplanter, but you have to be a solid general surgeon and a vascular surgeon, because the anatomy is such that it is much more complex than the kidney is, in many ways also than the liver is. The pancreas is attached to the duodenum, so you have gastrointestinal involvement. The reconstruction of the blood vessels is very different from the liver and the kidney, because it takes us 2 hours on the back table to do the bench preparation. It's a low flow organ with a high thrombosis rate. We are dealing with pancreatitis. Most of you on the nursing side, you're familiar with patients with chronic pancreatitis and acute pancreatitis, what it can do. The ones of you that have been dealing with patients that have pancreatic cancer, you know what treacherous organ the pancreas is. When the first pancreas transplant was done, people really asked the wisdom about even embarking on it. So it's a very, very different animal in that regard, and Dr. Sagi will talk about his experience in Wisconsin, and it has changed dramatically. He will talk about that because he was involved in the pancreas transplant programs, both the University of Texas and then at Mount Sinai some 20, 25 years ago, when the results were really poor. And I mean, this has changed and evolved like no other transplant field over the last 20 years or so. You know, this always happens shortly before they have the flood here. So, I mean, that's just the first indicator that a flood will be coming. I'm kidding, guys. I'm kidding. I have to be careful what I'm saying.